You go to the next talk with Mirza.
Just a second. Okay. Can everybody see the screen?
Yes, this is fine.
Yes, it's okay. Thank you.
Okay. Hello, everyone. I'm very happy to see familiar faces and my colleagues from WFNS Spine Committee. My name is Mirza Pojskic. I'm a neurosurgeon in Department of Neurosurgery in Philipps University in Marburg in Germany. This is where I work, nice small city just north of Frankfurt. And I thank for the opportunity to participate in this webinar and to show some experience on decompression in spinal canal stenosis. So first of all, I would like to point out that we at the WFNS Spine Committee, now this was before my term at the committee, but the Spine Committee as a whole have produced a lot of recommendations which were based on a Delphi consensus and which, in comparison to some other recommendation of spine societies, actually give you a pretty straight forward workflow and workup for all kinds of spinal diseases. You can find all of our WFNS Spine Committee recommendations at this webpage in PDF, and they are mostly in, or all of them are in open access articles. So I urge everyone to read those, and that can really help you in your everyday practice. And since we're a world federation, they are made for all continents and for all kinds of sorts of environments in which you might work. Now, when we talk about decompressive surgery for lumbar spinal stenosis, there is a paper of our friend Francesco Costa from year 2020 at World Neurosurgery X, also as an open access publications. And when we look at the evidence, you have several papers which compare surgical versus non-surgical treatment, where you also have confounding and bias by neurosurgeons, which define that surgical treatment is superior to non-surgical, that surgery is mostly indicated after 3 months of conservative treatment, and if adequate decompression, that microsurgical techniques are equal to open laminectomy. Now, these papers are 15 years old, and now we have emerging techniques such as minimally invasive spine surgery, which is already established, for example, decompression via tubes and dilators. And we also have endoscopic surgery, which I'm going to talk a bit about later. But however, these open decompressions and microsurgical decompressions, when we look at the world, at the whole globe, they remain still the leading technique which people all around the world use to decompress spinal canal stenosis. Relief of symptoms was found to be faster with surgery, in long-term superior to conservative treatment, superior in patients with moderate to severe symptoms. Meta-analysis of randomized controlled trials which showed that there is no benefit of surgery with respect to non-surgical treatment compared to non-microscopic techniques. But as Nikolai said before, it is very important to know that we are not religious when it comes to the indications of a decompression of lumbar spinal canal stenosis, and we are not religious or dogmatic when it comes to the technique. And I think the most important recommendation of the WFNS Spine Committee in respect to the decompression of lumbar spinal canal stenosis is that you use the technique with which you are the most comfortable with. So generally, indications which are in a system where I work and most of the Europe and the Western world is an intractable pain resistant to conservative treatment more than 6 weeks. Deficits with in patients with lumbar spinal canal stenosis are usually a bit different than in those who have a herniated disc or radiculopathy. A person with a herniated disc or radiculopathy will have usually one-sided pain, for example, along the course of L5 or S1 dermatome. A person who has a lumbar spinal canal stenosis, which usually have the so-called spinal claudication. Those people usually start to walk and then have to make a pause of the 10th 10, 20, or 50 meters because they get very severe pain in their back, radiating inconsistently to their legs. And one interesting finding which we found in our patients is that most of them are relieved by riding a bike. So in Germany, everybody rides a bike. So a lot of these people who have very severe spinal canal stenosis when riding a bike because of the opening of the neuroforamina have less symptoms. Neurological deficits, of course, if a paraparesis occurs or any kind of paralysis with MMC scale more than 3 out of 5 and bladder and bowel incontinence are absolute indications. However, there is a world of relative indications, especially in lumbar spinal canal stenosis. And in my practice, I usually combine wishes of the patients, talking with the patient and what he or she wants and what are their expectations with MRI, which needs to show a very severe spinal canal stenosis and the impact of it on. Hard to talk generally about this subject. There are some red flags, there are some indications which you always need to take care about, but there is a world of relative indications in between. When we talk about techniques, how to do a decompression of a lumbar spinal canal stenosis, we have laminectomy and hemilaminectomy with or without undercutting. Now, there are variations such as foraminotomy, which are actually, in my opinion, techniques of a decompression of a localized spinal canal stenosis. It goes more in the other direction. What I'm talking about is a severe bilateral spinal canal stenosis, which is also the most common. And techniques which you can use is microscopic in open technique or in MIS technique and endoscopic. This is a wonderful figure from the paper from the 2020 from our colleague Francesco Costa, and this shows the most common techniques. A is a standard posterior approach, open laminectomy and facet sparing. However, it is often so that the facets, the hypertrophy of facets is actually the reason for a very severe spinal canal stenosis. And if you do not decide to fuse the patient, at least the medial facets are going to go off during the decompression. Otherwise, you cannot achieve a good decompression. B, bilateral laminotomy. C, unilateral laminotomy with bilateral decompression, and the constant posterior element preservation under B and C. B and C techniques would be something which is almost dogmatically being used in Germany, unilateral hemilaminectomy with undercutting in order to preserve stability. However, randomized or long-term or controlled studies are missing because we have loads of patients who received laminectomies in the 90s, in the 2000s, which come to our practice 20, 30 years after surgery and have actually less symptoms and less instability than one would expect in terms of recent publications and recent dogma, which has evolved in direction of stabilizing or in direction of loose indications for stabilization. I recommend this book or this textbook, Pocket so spine surgery. Decided which level are we going to decompress. The most important thing is, of course, the localization. And this is a superposition of the spinal anatomy. I usually use C-arm. I think most of the world is the within intraoperative C-arm to find the localization. In Bosnia 11 years ago, where I used to work, if we did not have a C-arm, we used to put a metal clip on the patient. You have here the relationships of the dura and the transversing L5 nerve roots over this herniation or over the decompression. So on the downside, you see what is the amount of exposure if you use the open technique. Yeah, I usually use monopolar, and with monopolar cautery, I cut the muscles of the of the spinal process, retract them to the side. Then you can use a Casper retractor, or you can use the now there are different techniques how to do decompressions. Orthopedic surgeons and surgeons, in my opinion or in my experience, in Southeast Europe, in Asia and Africa, usually use Carrison punches. In the Western world, it's usually with a diamond drill. In neurosurgical warheads, you have the diamond drill as an established method for the decompression of spinal canal stenosis. And before doing a simple laminectomy, so how does it start? It does not start with the drilling of the lamina. It starts with the removal of the spinal process. Now, this is a very important pitfall. The ligamentum flavum has a usually very severe hypertrophy. And due to that hypertrophy, you have sometimes multi-layers of dura around it. And it can lead, if you don't do it carefully, very easily to the CSF leak. It is also very important to note that you should use your Carrison punch or rongeur always along the course of the nerve. So degrees to the course of the nerve entry or the nerve exit out of the spinal canal. And this is actually the final picture, which you should see under your microscope, and you should do it preferably with a microscope or with any kind of magnification. You have dura depression. The question if you should remove a herniated disc or remove disc at all in a patient with a spinal canal stenosis, it's important to note that spinal canal stenosis and herniated disc are two different diseases. However, it is not unusual that you have a patient which has both problems, which has herniated disc and the spinal canal stenosis. So there are people who are very dogmatic about leaving the disc when doing a decompression of the spinal canal stenosis, but I personally would always do it tailored on the patient and his problem. Beside the open technique, so this would be the open technique laminectomy. The open technique hemilaminectomy would be also this image, but only on one side. If the patient has one-sided problems or more problems to the one side, and the spinal claudication and the spinal canal stenosis, then in Germany, for example, it is very usual to do the decompression only from that side. It is possible to do the so-called undercutting, so to remove the lower third of the spinal process and of the elements, and to see through one side the whole dural sac and the exiting nerve roots on the other side. Now, there are no studies which actually have a very large evidence that this is in any terms good for the stability, but it is the way it's being done. And we would certainly need the biomechanical studies and the prospective randomized trial to give us more evidence on this. The emerging techniques are MIS techniques. MIS is in many parts of the world now becoming the leading technique for the decompression. For example, using tubes and dilators. You have here a description or a figure. What can you all achieve with the dilator. It reduces the muscle exposure. It reduces the pain due to the muscle exposure. There are confounding data if it reduces the complication rate or not. One big drawback with this and with the endoscopic technique is that you have a limited exposure, and that in case of complications such as dural tear or dural leak, you might convert this surgery to the open one, especially at the beginning of your career with this technique. Not only hemilaminectomy and not only unilateral exposures are possible with the MIS or tube technique, it is also possible to perform a minimally invasive laminectomy. Now, one might wonder, why is it possible to use a tube to spare 10 or 15% of the muscle exposure compared to the open technique, which is actually the technique with most of neurosurgeons are confident? There are a lot of different interests which play a role in promoting a certain technique. However, as I've said in the beginning, use a technique with which you are the most comfortable, and know that there is a MIS world which is going and marching on neurosurgery. And in my opinion, all neurosurgeons should also make acquaintance with MIS and with endoscopy, because it might become a standard of care. It is still not 100% there, and it's still not 100% sure it is going to be like that. But these techniques are getting cheaper and cheaper. So especially in the low cost setting, there might be something which is going to replace the open technique due to the less hospital stay, less in course of time, reduced operative time, reduced muscle exposure, and reduced muscle trauma. So this would be when using an MIS system and MIS laminectomy on the left side, the beginning of it, and on the right side, the thing which you see, which is very similar to the open technique, only through a tube. In my opinion, when doing unilateral hemilaminectomy or laminectomy, I still think that the open techniques are for the vision, especially in a severe spinal canal stenosis, are actually better. So we have this literature review from 2021, endoscopic decompression for the treatment of lumbar spinal stenosis, systematic review, where endoscopic decompression has shown comparable results to MIS and to microscope. And the patients who undergo endoscopy seem to have less postoperative low back pain, significantly reduced hospital stay, and trend towards less perioperative blood loss. We see here different techniques to perform it: percutaneous endoscopic or full endoscopic system, microendoscopic system with optical device attached to the tubular retractor, and biportal endoscopic system with separate viewing and working channels. And two main techniques, transforaminal and intralaminar PED. So I will go back to our recommendation and say that surgical decompression is an effective option for patients with moderate to severe symptoms. There is still no consensus whether microsurgical techniques are equal to standard laminectomy, and there was no consensus where unilateral laminotomy with bilateral decompression or bilateral laminotomy are not inferior to standard laminectomy. So laminectomy is for a very long time here, and in my humble opinion, it's also here to stay. MIS techniques have some advantages over open decompression, have lower complication rates, but there was no consensus if this is more effective than open laminectomy. And for oral complication rate and reoperation rate, there is also still no evidence which of these techniques is better. Complications, so general major complications, cardiopulmonary and stroke, go somewhere between around 2% with mortality of 0.5%. and 1% of new neurological injury and postoperative hematoma, with very common complication of incidental durotomy of almost 10%. And this is going to be in the next talk, but I will just show these three studies to show the discrepancy over the literature. These are three very large studies. One of them was published also in New England Journal of Medicine in 2021, multicentric study, 16 centers, 167 patients, 2 years follow-up. These guys followed or compared spinal canal stenosis with spondylolisthesis, decompression versus decompression plus fusion in patients who had a duration of symptoms over 1 year, with the primary outcome of a reduction of at least 30% in the Osvestry score. And they found out something which the neurosurgical community, of course, would largely disagree, that decompression alone was not inferior to decompression instrumented fusion. Now, this is a spondylolisthesis, which is postulated to be an instability, so spinal canal stenosis with instability of the lumbar spine. And there is also a work from Kleinstück where the fusion was superior to decompression alone, and the meta-analysis of 30,000 patients where decompression with fusion had no significant advantages over decompression. This is one of the cases from our practice. This is a patient who was 80 years old, who had a multisegmental spinal canal stenosis. And now is the big question in these patients, where to start, where to end, to fuse or not to fuse. In CT, we have seen that this patient had a ventral osteophytes in the 3, 4, and 4, 5, which shows the degree of certain natural fusion. This patient did not want fusion surgery. Otherwise, in a younger patient with such a severe spinal canal stenosis, it might come into question. And this patient had bilateral symptoms. So there are many options what to do in this patient. If he has or she has more left-sided pain and as a multisegmental spinal canal stenosis, one viable option is to perform unilateral hemilaminectomy over 2 segments, 3, 4, 4, 5, to do the undercutting, to preserve the stability at least on one side. Because if you see the axial image of this patient, there is no way that one part of the facet joint is not going to be removed during the surgery, because there is also no way that sufficient decompression can be achieved without it. And at least in the 4-5 level, you will usually have to remove a part of the herniated disc. So a tailored approach would be, in our eyes, a big thing to do it with all patients all together. So this patient explicitly had a unilateral decompression, did not profit, had a secondary instability, profited for a short time, had a secondary instability and was fused. This is the initial decompression. This is the amount of the decompression from lower to the upper part. This is what we usually do following the surgery. And this is now the photo following the final decompression with fusion. You would see screws somewhere here. And this is how it looks in the spinal canal, because this amount of removal you can only achieve if you do the fusion at the same time. So in cases like this, there are several options to do. To fuse him right away, and then you can remove all the elements which are compressing it, or to see what the patient wants, to see what are his symptoms and what are the other options, to do a unilateral hemilaminectomy, or just to do the laminectomy and see what happens. Now, this is another case, pretty similar to this. Now you have a very similar spinal canal stenosis, but here 3, 4, and 4, 5. Now there's also a theory that all patients with stenosis do have some degree of instability. However, you cannot fuse everyone. Not everybody wants it. Not every case is actually indicated, and a lot of patients have a natural fusion over the course of the time. So in these patients, we went for a unilateral approach or unilateral hemilaminectomy with undercutting. And this is actually only open on the one side, but you can see the entire scope of the dura to the other side. And I'm sure that many people who are also listening to this would say MIS is better, endoscopy is better. And I think it's very important not to get dogmatic or too excited about these things, and to use the technique which you are the most comfortable with. MIS for isolated lumbar stenosis achieves at least the same clinical outcomes and cost efficiency as the open technique. And there are some favorable impacts which were reported on surrogate endpoints for outcome, blood loss, hospital stay, and wound infection. And shortly complications, neurological deficits 1 to 2%, dural injury, still the most common complication of 10%. In treatment of dural injury, it's always good if you can find the spot and suture it, if it is in a place where you can suture it. If not, then to put a Tahosil or to put a lumbar drain or to put a Shavita or any kind of foreign materials which you use for a hemostasis. Delayed surgical hematoma, instability plus minus 20%, and reoperation rate of 15%, and general systemic complications which between 5 and 10%. Thank you. I would like to invite everyone to submit to our special issue in Journal Medicina, an open access journal. It is going until the end of August this year. And this is one more photo of Marburg. And you are all very invited to visit the department, especially our technological suite with intraoperative CT and robotic arm. Just let me know on my email, which was on the beginning of this presentation. Thank you.
Thank you, Mirza, for the talk and your invitation. We are late on the time, so we can take one question or comment.
I wanted to ask to Mirza Haydara, Professor Haydara. Thank you, Mirza. It is a wonderful presentation. I know you frequently use MIS technique, and I wanted to ask you, what are your limitations for using these MIS techniques in lumbar stenosis? Because I know you are select a lot of patients to MIS techniques. And where is your limitations?
So we use MIS mostly for percutaneous pedicle screw implantation, but when it comes to spinal canal decompression, we still use open techniques, mostly unilateral hemilaminectomies with undercutting. That would be the most employed technique in our department and in our experience.
Thank you.
I have a question, please.
Question?
Yes. Most of the times we come across a situation in which we have a patient of maybe 55 or 60 years of age with multi-level stenosis on the MRI. But clinically, the patient only complains of claudication and the motors are intact. The sensations are maybe plus minus, but mainly the motors are intact and the sphincters are also intact. So what is your approach in these patients in which you have intact motor function with sensory impairment but severe claudication? Do you go for conservative or do you operate?
That's a very good question. Thank you. So in multi-level spinal canal stenosis, where you think from the preoperative MRI that you would need a decompression of 3 or more levels, this patient obviously has then in long term an increased risk of instability. So you try to lead this patient conservatively as long as he or she can. But of course, if the conservative treatment is not good, if any deficits happen, then I would always go for the unilateral decompression of the side which is more severely stenosed than an MRI, and with undercutting, and then see what happens. The difference is if it has a very severe spondylolisthesis or any kind of secondary instability. Now I have a comment in chat that many times we decompress one side by hemilaminectomy, and after a few days they complain pain on the other side. That's also something which we observe in my practice. It happens, but I think with proper undercutting, that happens less. If you see the entire scope of the dura to the other side, and sometimes also the exiting nerve roots on the other side, and there are several options of injection techniques in the facets, on the contralateral facets, which sometimes are responsible for this pain, because biomechanically you have now a bigger pressure load on the other side, which is not decompressed. That would be one strategy.
Okay, thank you.
Thank you.